What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
My name's Mark. Okay, so today we're going to talk about what it looks like once we get into the physical portion of the exam, more of your objective measurements. In our previous episode, we talked about what the subjective evaluation looks like, and naturally what follows is the objective part. So one thing that I try and do when it comes to the objective exam is to keep it as consistent and as reproducible in between patients as possible. So I find that at least that there's a lot of different things you can do when it comes to the physical exam, all kinds of different tests, measurements. I try and keep things standardized to some degree, so that if I have a patient coming with a similar presentation and I minimize variability on my end, I can at least start to develop these patterns that I see, and I get a better idea of how different presentations respond and what I would expect to see physical. Kane, what do you think? You got anything, just generally that you kind of try to do when it comes to the objective for?
No, I definitely agree with that. I keep things as consistent as I can. It doesn't even really matter that much for the body part that I'm looking at per se. I will add in things that are tailored to that body part, but in general, if it's like a neck or a thoracic spine and then upper extremity thing, my initial physical exam all stays very consistent. Same thing for if I'm looking at low back, hips, knees, foot and ankle, etc. That has its own thing, but everything stays consistent until we get into like more specifics for that joint that I'm looking at. So that just makes it so that I cover all of my bases. I get all my baselines ready to go. And I mean, if I'm missing anything, I know that I can always take a look at it the next time that I see the patient or just later on during the exam.
Sure. Yeah. So you try and keep consistent as I do. Yeah. Do you find that how I had mentioned before, you find it helps you start to develop these patterns, start to get a better idea of, someone comes in, let's say with like, anterior ankle pain right along the kind of talocrural joint and like something like that, get that subjectively. Do you find that standardizing your exam helps you expect what you would expect to see objectively?
Yeah, so it does a couple of things. And I mean, when you said your rationale for why you standardized it, that definitely makes sense. It's not the primary reason why I started standardizing my exams, but I could definitely see that being the case. For example, like if I go through an exam, I do the same exact stuff because that is when I can kind of go into autopilot where I just make sure like everything's all good. This is checking off all the boxes that I need to check off. We're safe and everything is like fine and normal. If things aren't going how they normally should, and I kind of come off of autopilot, that's when I know that we're having some other concerns that I should be considering. And on top of that, like if things aren't presenting how I would initially expect them to present, that definitely takes me out of that autopilot mode a lot faster, where that pattern recognition that I would have expected to occur just isn't fitting the classical pattern that I would have wanted to see. Okay. And so that's where I have to troubleshoot and problem solve, and then I can kind of decide how do I want to pivot during my physical examination a little bit more. Yeah. What about for you?
Yeah. So, and then just building off what you said, you're talking about maybe red flag type symptoms bring you a different direction. Assuming when you talk about getting off autopilot, things you're not expecting.
I mean, or even some of them are like red flags, but just like different presentations of it, like maybe someone has like asymmetrical reflexes. Does that mean that it's something that I need to be super concerned about? Maybe not. If I'm seeing like a random dermatome where they have a slight loss of sensation, is that something where I need to be concerned about? If they have a huge chunk of it where it's like completely gone and numb, that's when I might be a little bit more concerned.
Right.
You
Okay.
know,
So these things are getting
but
put on your radar as you're going through it.
sure. And
Gotcha.
that's kind of how like I kind of have like a checklist of things that I expect to see, things that should be normal. And then as you go through the exam, here's your other checklist that you need to keep in your head, which is these are things that I'm finding that aren't normal, that aren't fitting the presentation that I would expect to see.
Sure. Okay.
So
Gotcha.
when you go through your physical exam, what are the primary components that you are standardized and taking a look at consistently?
Yeah. So the first thing I look at typically, regardless of body part, is range of motion. Yeah. And like one thing I wanted to point out too, first couple of years coming out of school, you learn this kind of stuff in your class, range of motion, MMT, reflexes, stuff like that. But yeah, when I was coming out of school, I thought, oh, these are basic things. Like I got to look for I really got to look for the answer within the physical exam. I got to look for some kind of complex special test that's going to lead me to the right diagnosis that's going to dictate my treatment. But over time, I found that the simple things, range of motion, which is typically the first thing I look at, MMT, just your general strength thing comes second. Those are what I find I get the most amount of information from within the objective part of the exam that starts to guide my treatment. So, yeah, range of motion. Okay, what's happening when they move? What's happening when they get to the end range of the movement? What's happening after? Yeah, same thing when we're testing MMT, right? We're looking at, okay, are you able to produce this amount of force this position, and let's say arm by your side, arm straight forward, right, overhead or in towards end range. You're always looking at the response, right? What's happening during, what's happening after, are your symptoms changing any? Yeah, so typically range of motion, okay, looking for any kind of limitation, any kind of production or any kind of change in symptoms while they're doing things. And then we look at the same thing with MMT, and I find that I get the most amount of information off those two measurements, and then we can start to go into the other things, right? Reflexes, upper and lower limb tension tests, right? Maybe we can work into, we can discuss this later too, as we can get into maybe a little bit more fine detail type things. But I really find the range of motion and just basic range of motion, basic manual muscle testing gives you a ton of really useful information, easy to do, easy to standardize. What about you? Anything you start with pretty consistently? Anything you find that really helps you start to come up with a plan for the patient?
So I definitely agree with the priority that you put in regards to your range of motion testing and somewhat for your manual muscle testing. My order pretty much always stays the same. Like it really doesn't change much. So I always check upper lower quarter screen. I do my dermatomes first, and then I'll do my myotomes next. I'll usually toss in like the cervical range of motion while we're there to pretty much start off just to see because it's quick and easy. And then after I just kind of go on and check to see the pertinent like range of motion and muscles that we really need to strength test. Now, for strength testing, to me, I actually don't derive a lot of value from the grading scheme of a manual muscle test. If a side's a little bit weaker or a little bit stronger than the other side, I really don't care that much. My biggest thing is there a gross difference? Is there like a huge discrepancy between like your movement quality or quantity from one side to the next?
But not
And
something
then
where like this side's a 3 and or sorry, this side's a 3 plus, and then we got like a 4 minus on this side. You're not getting a ton from that grade.
No,
or
it really doesn't tell me that much. That's the thing.
yeah,
It is like
yeah,
maybe you're just really dominant on that
yeah,
side,
sure.
and that happens. Like that could be the problematic side too, you
Yeah,
know? So it really doesn't tell me a whole lot there. I think if we're able to produce your symptoms, that tells me a whole lot more when I do a manual muscle test, because then it becomes, oh, we're checking things out in an isolated manner. Because, you've probably had patients when you're like, when does your pain come on? You're like, oh, when I do like this particular motion, or when I have to find it. And then to
there it
me,
is.
it's just like, okay, let's try to break that down.
Yeah, yeah,
If
yeah.
we're able to reproduce it every single time consistently and in a simple manner, like in like either a sagittal motion or a frontal motion, or anything along the lines of that, that just made your life a whole lot easier, right? So
True.
like
Yeah.
people when they're like, oh, I have shoulder pain and it only hurts when I do X, like X motion, and they show you some really obscure thing that you would never ever imagine them doing with their shoulder, and then you check their maybe external rotation. They're, oh no, that's my pain, and you're like, oh well,
Hmm.
that's easy enough,
Yep.
right?
Yeah. Yeah. We simplified it, right? Versus like, oh, it only hurts when I horizontally abduct my and extend in internal rotation while I'm driving. Yeah, something weird.
Yeah, so it's like if you're able to do that for yourself at least, I think that there's a lot more value there. The patient may not care, but they'll also be, oh, that's another problem that like I didn't know that this was an issue. But for me, it just helps to simplify that process where I'm like, okay, no, this is what the actual issue is. That the motion that they're doing is affecting it, sure, but to make it make sense in my head, it's like, oh, okay, so if ER is the issue, that's probably one of the things that we can focus on, and at least keep it on like our radar as
Yeah.
something that we may need to take a further look and investigate a little bit more into.
Right. Yep.
So when you're going through your exam, do you consistently do dermatomes and myotomes? You consistently go through an upper or lower quarter screen? Because this is a topic of a little bit more contention that I've had with more experienced clinicians
Okay.
compared to like newer
Okay.
ones.
So upper lower quarter screen to me is dermatome myotome. That's kind of what I hear. Is that what you're
Reflexes
talking about?
too.
Okay. Yeah. So
Yeah.
I mean, I'll tell you this: unless there is like if I'm not getting subjective reported like numbness, tingling, burning, neurological, or we'll just say like nerve quality type pain, spine involvement, like, or unless I think there's like a red flag type thing, I don't do reflexes a ton, just because it's kind of lower on for me, lower on the totem pole when it comes to test retest, and also in terms of what I would call like testing reliability, at least like just the amount of people that you'll do like an S1 reflex on, and it's just like you know quote unquote absent, but it's absent bilaterally, and it's just like is this person just um aware of it, if if they don't have any other kind of neurological signs, and I'm not worried about like doing the reflex on top of that, for me doesn't add much value. So unless it's like a I really think it's a radicular type pain, unless I really think there's other red flag type things going on, not doing reflexes too much. um yeah, sensation I'll do, um just to get baseline type things, but it kind of, to me, it falls into similar category to reflexes. Like, if I'm suspecting something red flag, if I'm suspecting something ridiculous, but also like when it comes to test retest, when it comes to how we're implementing treatment, it's just lower down for me. Like it's just like, you know, unless it's like completely numb, people are, oh, maybe I feel it a little bit less on that side. It's like, is that good enough? There's no way for me to know if it's there or not. So yeah, when we're doing upper lower quarter screens, like those are the only two things that I maybe don't do every single time. I will do them if I find that it's going to provide me value, right? Or not, if it's going to provide me value, and for the sake of rolling, um, any other kind of conditions in or out that I think could be going on. But when it comes to like MMT and range of motion, yeah, I'm doing, or use myotomes, yeah, I'm doing myotomes. Range of motion, I'm doing that. But yeah, reflex, rare reflexes, sensation, the sensation dermatome part. It depends on the individual. Like if someone came in and they had, you know, let's say shoulder trauma 2 weeks ago, full neck range of motion, um, no subjective reported numbness, tingling, um, otherwise fine function. They just have like low grade shoulder pain that's gradually improving. I don't know if I'm doing reflexes or something there. But is it
Okay.
something that you do pretty consistently? Do you find that gives you a lot of value, or
I pretty much just do it out of force of habit at this point.
okay, okay,
Dermatomes for sure, just because of how fast they are. Like,
yeah,
I'm not doing anything crazy with them. I'm not doing like 2 point discrimination, sharp dull
yeah, yeah,
testing,
yeah,
anything like that. It's just a quick gross screen to make sure everything feels relatively the same.
okay,
So that I've just put into my examination because it takes a total of like 20-30 seconds, if
yeah.
that.
You just quick
uh,
light touch, and then
yep. And then reflexes, I have started trying to capture them a little bit more often, more specifically for people who have spine issues. Like if they are having any ridiculous symptoms, I am almost always trying to check reflexes now, just to make sure that if something changes, we kind of know, and then we have like we have their original baselines. So if things progress, then we want to make sure that like we know that this is something that's different and that this wasn't what we saw
yeah,
initially.
sure, yeah. Without getting off subject too much, it's just quick. You find that when it comes to retesting baselines, do you find flexes um can change, or do you find it's a for you can be a, like, where's it fall for you? You find it's like a pretty reliable indicator if someone's like improving, if it's the right person, or do you look at other things first?
I definitely look at other things first. It is not the first thing that I will go to if I'm trying to determine if there is an improvement. It is a potential comparable sign for me where if I am getting like a normal reflex on one side and on their symptomatic side, it is completely absent or it's
Yeah,
like minimal, and we try an intervention, and then we can check to see, because that to me is like a standout. Like, oh, there's a stark contrast
yeah,
there. If one
especially if
side
one
was
side's
like,
normal, right? Yeah,
yeah,
yeah, yeah,
if both sides were relatively normal and there's like a little bit of discrepancy, like maybe one is normal, the other side is like hypo reflexive, a little bit less brisk, then
sure.
to me it's like that's not the biggest thing,
Yeah,
like
yeah, right.
it could happen to anyone. But if there's like a stark contrast, then yeah, I'd want to see if there's a change. If there's a change there, that definitely tells me some pretty relevant information. If there isn't a change, it doesn't mean that's like that what we're doing is wrong, but it to me it's like if there is no change, not a big deal. If there is a change, that is significant to me.
Gotcha. Yeah. Okay, so we got how about, so regarding the upper lower quarter screen, doing your MMT strength testing type things, are you doing the, we'll call them resisted isometric type thing? Are you getting them into the standardized like MMT positions, or do you find that, yeah, how do you do it, and what are you looking to get out of looking at the, we'll call it let's just generally call it the strength screen.
So For certain things, I am going to take them and put them into their traditional testing positions. But for example, like shoulder stuff, definitely not. Like a lot
Yeah,
of scapular positioning things, typically not putting them in prone and then
yeah,
going through all those manual muscle tests. I just don't find them to be necessary or reliable or anything like
sure.
that. The one thing, and I'm not sure if this is taught to everyone, but at least the way that I was taught, and I've actually been considering putting this back into practice now, is that the order that I was taught traditionally was going through range of motion testing. And then after that, going through a resisted range of motion and
Okay.
then going into manual muscle testing.
So letting them
And so
move, but you giving them resistance, but not so much that it stops their movement.
exactly,
Mm.
exactly. So you get to check out to see what their quality of motion is like when they're actually going through a movement. And this typically happens when you're going through like any manual muscle test is it's an isometric. They're not
Yeah,
moving.
yeah, yeah.
So who knows if it's provocative or not at that joint angle. Maybe that joint angle is provocative for a lot of people. And so this is triggering their pain, or maybe that position is just not doing anything for them. And so
Um,
you just don't know within that range of motion, right? I think
yeah.
the easiest one to really see would be like if you have a knee or like a rotator cuff issue. If you have them wind up all the way in ER and then you try to manual muscle test them, that's going to crank on that tissue a whole lot more versus if you have them more internally rotated, they're going to have a little bit more room to work with. So that kind of tells you a little bit more like how irritable that tissue is, maybe where in the range they're more sensitive in and stuff along those lines. But it's something that I've been trying to implement a little bit more into my practice to see like, is it going to give me any more relevant information? Can I tailor my interventions in my exam to be more specific to the deficits that I'm finding there?
Gotcha. Yeah. So, you said about people doing that after range of motion and how you would, how if you try to implement it after range of motion, look at your resisted isometrics, let's say arm side type thing, see the, just seated at the edge of the table, or where do you think you'd throw?
I mean, it to me, it doesn't really matter that much. I
Yeah.
think if I put them like I'm gonna do the range of motion first, and if I'm gonna do resisted range of motion, I don't care if it comes before or after the manual muscle test. That to me isn't super important, but the thing is like if I am already strength testing them and I'm finding something is like really provocative or like this joint that they're telling me is bothering them, I can't get anything out of it, then I'm gonna continue checking a little bit more, because like if that one position hurts and then I change it and they're like, oh no, that feels better, that definitely gives you some relevant information, versus like if you check it and they're like nope, everything feels good, and you check the entire range and you're still getting absolutely nothing there, that tells you that maybe that they're not going to respond in an open chain position. Maybe they're not going to respond with isometric loading. Maybe it needs something else,
Yeah, yeah, yeah.
you know?
They change the position or the general context and how you're testing. Yeah. Yeah, the one thing, I mean, I don't do like manual resistance through range, but someone tells you like, hey, I got this shoulder pain and I can move the arm like this, and that, it doesn't, but like, if I try and put something in the top shelf of the cabinet, like a plate or like a bottle, then it hurts. And I'm like, all right, cool. So what are you lifting? Okay, you know, plate, it's stone, it probably weighs like this much weight. Just for the sake of standardization and keep it consistent. I'm at that scenario, especially if they're active range, there's just isometrics and different. It's fine. I mean, I'm grabbing them a dumbbell and just having them go right through it. Just something like that. I mean, it can be lower extremities, whatever kind of. But yeah, that's definitely a specific instance where I'm not leaving there, right? Full range, this is isometrics, and like you said, you got to find some other way, um, get the information you want. So we can even
Yeah,
expand by, you said, resistance through range, whether it's manual
yeah.
or and something else.
Sure. So I think that ties in with our previous discussions too of finding that comparable sign, right?
Yeah,
Like
yeah,
most of the things that we've discussed so far when we are going through our physical exam is we're trying to find we're trying to first establish baselines, and then secondly we are trying to find a comparable sign. Doesn't really matter how you do it, but it we need to get there in one way,
has to be
shape, or
identified.
another. So now, when you're going through, when you're manual muscle testing someone, I always find this to be super, super funny because they'll say manual muscle test is very subjective, right? It changes from one person to the other. Totally get it. Really makes sense. When I see manual muscle tests from physicians and I just see 5 out of 5 for everything, and then I go and manual muscle test, I'm like, this is not the same.
Yeah,
I'm wondering, like, how hard, how much effort, and
sure,
how
sure, sure.
long are you sustaining, and how, like what are you typically doing when you're going
Gotcha,
through a
for
manual
sure, for
muscle
sure.
test?
So when when it was taught to me in school, and I rejected this immediately, they said, "All right, no one should be a 5 out of 5." Well, they're okay. So why are we even learning that grade? Doesn't make any sense. They're like, "You're testing hip flexion. You should be jumping on their leg." It doesn't make any sense. I was just like, "There's no value in this if no one is ever be the highest one, right? You, it doesn't make any sense. There's no the top end like doesn't exist. It's unattainable." Similarly, when I've had PCP visits, it's like, they're having you do scapular elevation um, uh, for your traps, and they're giving you 2 fingers of resistance on each side. That probably does nothing either if you're trying to rule out a neurological condition, right? Um, so typically, how I start it, I give enough resistance to match. I'm kind of feeling out where they're at, and then I gradually increase the resistance to the point where um, they're not able to provide the amount of resistance to in that position, right? So let's say they're at 90 shoulder flexion. I'm pushing down, maintaining it for a second or two. I gradually add resistance to see when they start to break. If they're going to be a 5 out of 5 on me, then I want them to maintain this, that gradual increase of resistance till, whatever my top end is for at least a couple seconds, right? I mean, we're not hanging there all day, but I want to know that that tissue can handle that amount of load to maintain that position for at least like let's say like 2-3 seconds. But you know, like if we're testing a smaller muscle group, let's say it's like 99 ER prone, something like that. Like yeah, I could probably break anyone there. I just don't see value in getting there. Yeah, like I said, there's a large degree of subjectivity to this, but like I'm giving enough resistance that I know that this tissue isn't irritable in this position. You know what I mean? And I'm doing this with the understanding that um, I'm at least trying to mimic the maximum, if not more, amount of force that these tissues are enduring through this person's daily tasks, whatever it is, whatever I learned from them, subjective, whether work, whether it's like going to the gym, whatever that is. So yeah, I try and keep it specific to the patient, but I'm really looking to get. I find that I get the most useful information by giving enough force, enough resistance, but like it doesn't have to be something where I'm just like absolutely crushing them. Right? It doesn't make sense. I don't have to break them every time to get the necessary information. That makes sense.
Yeah, for sure, for
Yeah.
sure. I think like the approach that I do is similar. I've been taught to initially do the hold, and then you increase and then hold again, and then on a third hold that's like your max, right? So I do something similar to that, where it's like I will gradually increase my force, just like you said, but it becomes like a step. It's like gradual increase, hold there,
Yep.
another gradual increase, hold there, and
Right,
then
right, right.
another gradual increase, and then hold, and see what they're able to do. And I think it definitely ties into what you're saying. Like, are they able to hold and maintain that position for some time? Because then we actually get to see, is there muscular fatigue? Is there
Mhm.
like a neurological fatigue that's going on? Does it just drop? Does their pain come on all of a sudden?
Yeah, yeah, yeah.
Does it take time? Or what exactly is going on? What is their response
100%.
to it?
Yeah, even like
And
you
I
said,
think
yeah, you said about fatigue too. Like great point. Like when we talked about you talked about providing resistance through a range of motion. What if someone, what if they do that once, right? Okay, maybe let's have them do 15 times in a row. Like keep working it. Okay, now it starts to hurt. All right, you do a couple more reps, giving them resistance through the range. All right, now the symptoms begin to worsen and they're staying worse. Right, that's a lot different than okay, we gave them resistance to the range once and um they didn't have any symptoms. But yeah, so different ways you can begin to identify, expose any kind of objective measurements you're looking
sure, sure. This is the one thing that I'll say that I definitely do not standardize in how I test. Like, if I'm gonna test like a 20 to 30-year-old power lifter versus someone who's coming off of a total knee, a five may look a little bit
for. Yeah,
different,
yeah,
you
yeah, yeah.
know. So like if that is like they're strong, but
Mhm.
you can't hold these people to the same standard across the board. That is
Definitely
definitely
not.
not
Yeah,
fair.
yeah,
Right. So like the 20 or 30-year-old may be super strong relative to the 60, 70-year-old, but they may still have like issues where like when I manual muscle test them, they're gonna budge more. And that's where I'm looking more at like their quality or their endurance and how they're able to
yeah, yeah,
maintain some of those positions. For the older folks, I'm not pushing quite as hard, but I still want to see if they're able to maintain some of that. And then when I push adequately, I'm like, okay, no, they're
yeah,
strong.
yeah, yeah.
I don't foresee any issues. So I don't have that a problem with giving them a higher grade. So most of it, like I said, the grade to me is not really important. It's more about the other information I can derive
Yeah.
from the test itself.
Yeah, I mean, I use that 0 to 5 system just like as I mean, you document it some way, right? But it's just kind of gives you a little bit of an outline of what to look for. I think similar, like we talked about, um, depending on the patient presentation, the objective measures you would look to or that you would expect to see based on the presentation. Yeah, like we can quantify it to some degree with MMT scale, so we can use it in that regard. You ever like you talked about maybe someone who's a bit stronger has a little bit more to give. Using dynamometry at all to quantify the strength or
So
force output in any certain positions?
I have not. It is
Hmm.
just not something that I've really built into my
Yeah,
template. It just takes more time, more setup. It
yeah, yeah,
doesn't seem to be really relevant to me.
yeah. No,
Um, if there's like a glaring difference, then sure, I could totally see justification for it. But I think the same thing goes for if I'm doing grip testing, right? If I'm doing grip testing, to me, is there going to be a difference side to side? Sure. Is it going to be a stark difference? Maybe not. That could be normal. If it's something that to me is like perceivable, where it's like,
yeah,
oh,
yeah.
I'm feeling a huge difference here.
Right, right, right.
Okay, you should be able to feel a difference on if it's changing or not. Right? Like if it's a significant change that you're expecting to make, awesome. You should be able to feel that. You don't need a
Yeah, yeah,
dynamometer for
yeah,
that. But if it's something that's more gradual improvement, sure, you could totally break that out and then check and get your data. But that's just not typically what I default to, because how many people really care that their grip strength is going up by like 2 3 pounds per
yeah.
square inch?
Exactly. Yeah, it's like
You
the
know, like
same
the
when people are busting out the goniometers and like, oh, your shoulder flexion went from 160 to 170. I mean, first off, like unless the person's telling me, hey, now I can put this plate back in the cabinet now and it doesn't hurt. I mean, maybe their range of motion got better. I don't, or if it got better and they still couldn't, perform that task, I could not care less about measuring that. It's like you said, it's like, oh, your grip strength changed a little. All right, your knee extension torque, increased by 5 pounds. That's good. I still can play soccer. All right, well, yeah. Right now, there's
Yeah.
situations where we want to quantify, like, we can talk about knee extension strength for knees or whatever. Yeah, we get that. That's something we use. But like when we're looking at people who are, general population limited in participation or whatever they're doing because of pain. Yeah, I mean, someone who's in pain and still can't do what they want to do, but their strength got a little bit better. I don't know if that's going to sell them.
Yeah, I think so there's kind of a caveat there. At least for me, there are certain things where yes, that those numbers matter a little bit more. So like for knee flexion and knee extension for post-op patients,
Yeah, yeah,
that's
yeah,
gonna matter. That's gonna matter more for me, right? Like we need to get to those ranges and we need to get those to improve to be functional. On the flip side, I you could very easily argue, oh, your shoulder range improved by X amount. Does that matter? Does it help anymore? Maybe, like if you get an extra little bit, they feel a little bit looser, they feel a little bit better, but it hasn't really made a giant change.
yeah,
And
yeah,
then I've also seen it where if you have like an overhead athlete or you have a crossfitter or an Olympic weightlifter where their range of motion isn't the best when they are just standing there or tested in isolation. Bodies don't necessarily move in isolation. And so when you have them do their sport and they end up doing better, that to me is huge. So what if their range of motion didn't improve, but their
yeah.
control over their joint has improved? And that to me is going to be like, is a huge thing. And I'm sure that that's going to be a lot more important to them than seeing a number go up by a little bit, by a few degrees, you know?
Yeah. Oh, yeah, yeah. I mean, listen, if number go up, I love it. But yeah, it's hard. It's hard to get those small changes, right? It's we're looking for the big noticeable things that patient notices, and then we can easily notice it as well and explain to them why a good change. Okay,
Yeah,
how? Yeah, go ahead.
there was one quick thing that I wanted to touch on actually, and it was something that I got from one of my mentors, and it was something that I didn't really consider, which was ER manual muscle testing. I think is something that for a lot of my patients now, I do not crank on them. I do not try to push them to see if they're going to get to that 5 out of 5. I'm actually trying to cue them to do less. At first, I kind of see, does their cuff actually kick on at all, and where do they feel it kick on? And then after that, when I apply more and more force, does it change? Do they start to shift the load over to their bicep tendon, which is super super common? So that is one of the things where it's like work, do less. So
Yeah,
I
yeah, yeah.
usually will add that for my patients where I tell them, hey, the other ones I want you to fight me, this one I want you to as well, but I want it to be targeted,
Gotcha.
so like
Yeah.
I may check to see what they do unprompted, but later on I'm definitely going to check
Okay.
to see if they're able to recruit it better.
Okay. So maybe like you talked about, movement quality is something you take a look at, and then you will, like I said, unprompted, see what it looks like, and then maybe you're giving them a little bit of cueing just to see if they're able to perform whatever the movement is or the task within, the kind of, or at least in the way that they should.
Yeah, I think the same thing goes for like if you're checking glute med, right? Because
Hmm.
so many people will just go right into hip flexion. So if they can't do that, I can't really manual muscle test them no matter what.
Yeah, yeah, yeah. Right. Gotcha, gotcha. Okay, so you had
So
this similar with the shoulder ER, right? So we'll take a little
yeah,
biceps.
very,
Okay,
very similar.
gotcha. Okay, how about I'm sure we could talk, but we can make this an entire episode. Okay, movement exam, right? I think I mentioned a little bit when we're looking at range of motion, what's happening, baseline symptoms, what's happening during, what's happening end range, what's happening afterward, right?
Do
Let's
you,
yeah,
when
go
you
ahead.
go through range of motion, do you check over pressure?
For extremities, yeah. Yeah, for
What
sure.
about for what about for spine?
I mean, how should I put it? It's so I think okay, let's start cervical and thoracic. Um, you know, if I really think it's some kind of cervical derangement or um then or there's just something cervical or thoracic and nothing's happening, right? Yeah. But I see movement loss, but let's say they don't have pain. Um and gone through our repeated movements and we've gone through everything and nothing's changing, I'm gonna add overpressure just to see if we can expose something, right? But um I don't um I haven't found the need to do so on any kind of consistent basis. I can think of like a handful of cases, maybe like with rotation or retraction, where like oh yeah, I can turn my head and it barely moves, and then we add a little bit, I can move them farther, and then they have symptoms. Okay, cool. Now we're looking at now we can start to work with something there. Um, Maybe the same thing for thoracic. They just have they have really minimal extension. We get a little bit of overpressure in there. Um, have them extend a bit more, then it begins to hurt. We work into it, it gets better. Okay, cool. So yeah, and sometimes in cervical, sometimes thoracic, definitely extremities, lumbar spine. They, unless we're talking about like clinician courses, in
Yeah.
terms of like trying to find a reductive movement. Yeah, I mean, I'll use that for sure. But like, if just having them like do like thoracolumbar rotation, like sitting, like I don't add too much overpressure within the bounds of the movement exam. When we get
Mm.
farther along, maybe. But if I'm just watching them move, I'm typically not doing it for lumbar. Where I do it the most is extremities. Like they just move a lot more, especially when they're looking at shoulder. Knee extension. A lot of people aren't getting end range on their own, so I got to see what happens if we really test that joint out. But yeah, I think there's definitely some unique value to watching the individual move on their own, seeing how much they're able to move their own, and then gauging the response from there. Then we can start to add overpressure if necessary.
Yeah, so I definitely agree with that. When I go through an extremities exam, I am definitely giving overpressure for the the cardinal planes of motion,
Yeah, we
Um shoulders and knees in particular, sure, and hip flexion typically, because those are going to be like the more provocative ones. Cervical, I definitely will check overpressure for all the ranges. Lumbar, I don't check very often. Same thing with thoracic. If anything, I might just check for flexion to see if they're not having any issues there. Then if we can provoke it, then that tells me a little bit more. But cervical, I've actually found it to be a lot more common, where they'll tell me that they have like ridiculous symptoms, and then they go through their range of motion, and it could look absolutely normal, or it could be limited, and then just pain free. But as soon as I add that overpressure, then they're like, oh, that's my pain. I feel it
yeah,
now.
there it is. Yeah,
And that
exactly.
tells me a little bit more.
Yeah, which
So
is
that's
like
the
we
only reason why
can.
I've added that.
Yeah, I mean, you can draw a parallel to how you stated where maybe resistance isometric's fine, range motion's fine. You add resistance through range, right? We can. I mean, adding overpressure to the range of motion. It's just another way to further test out that joint, try and see if there's like I said, you only get a little bit of you get a piece of the you get some information from looking at active movement. Yeah, overpressure gives you some more information as well.
Sure, sure. So, what else do you typically do for your movement exam? Like, what else do you include? For me, it's basically range of motion, lumbar, cervical screen for their range of motion, and then capturing a couple of other functional movement patterns. Like maybe a squat pattern, heel toe walking, what their gait looks like, and stuff like that. Sometimes, depending, I might throw in a step down um if they're complaining of knee or hip pain. And to me, if
Yeah,
it's like not lumbar related.
yeah. I mean, it's eh, depends on the case too. Like if I'm someone's coming in like anterior knee pain, chronic type thing. Yeah, and they're telling me, oh, when I go to the gym and it hurts when I do this. All right, I'm gonna look at squat. Let's look at like a single leg squat to whatever range they're comfortable with. Step up, step down, lunge, all that kind of stuff. Right? I'm just trying to see if there's anything that they're symptomatic with. Again, like just like we talked about range of motion, MMT, like it's nothing. I'm not looking for anything, any kind of special movement. I'm just trying to see, like, okay, what are you doing on a daily basis that you're getting symptoms? You know, trying to see if there's anything we can start to add just to get the full picture here, right? So for lower extremity, squat, lunge, step up, step down, some kind of single leg squat if it's appropriate. Upper extremity, um, I'll look at like, I mean, if you want to call it like a functional thing, behind the head, ER, right? And I'll really have them like horizontally abduct their, I guess, really their elbow just to like really reach back.
Mhm.
Um, Behind the back, internal rotation, right? And then just reach up as far as they can. Maybe have them go across. Yes, I guess upper extremity I don't do as much for unless it's like the person's like has some kind of real specific movement they look at.
Yeah, I mean, to be fair, I don't even do the Apley scratch test that often. I just
Wait,
started
I don't
doing it
even, dude.
more.
I don't even know what that is. You gotta tell me what it is. Am I doing it? But
It,
but I don't know
yeah,
what it is.
you're literally describing it. It's the test where you go one hand goes behind your back, like you're trying to scratch your back,
Yeah,
and
yeah.
the other one where it goes behind your head. So you're just testing both simultaneously and then just seeing
And
if there's a gross deviation from side to side. I started doing it more just to get a quick comparison, but the reason why I don't like that test, and I've been told by a lot of people that they love it because it's a functional movement, right? But to me, if you go through that test, there is a very good chance that you're going to get a huge discrepancy, and
yeah,
they're totally fine. Like I've
yeah,
like my shoulder is bad, so on my left side there's a huge difference going from internal rotation on that side versus on the other side. Like it's completely different, but I don't really have symptoms or anything that's
yeah,
any significant deficits with it.
yeah,
So that's why to me it's like not always the most reliable. I still check it just to see, can we make an improvement? Does it recreate your pain or anything like that? But I don't put as much stock into it compared to like other things, for example.
yeah. And I mean, I think we'll talk about this at some point in a future episode, but like um contextualizing these impairments and being able to understand and identify if they're relevant or not. And yeah, a whole different subject, but good
Oh
point
yeah,
there.
that's gonna be a
Yeah,
really,
yeah,
really big episode, I feel like, because
yeah,
there's
yeah.
just so much nuance that can go into
Oh
that.
yeah,
But
and it's like,
we'll hold off
yeah,
on
yeah.
that.
I'm getting excited. I gotta stop. All right, back to movement exam. Yeah, I mean, so yeah, I'm looking at these functional movements. I think the big overarching thing I'm looking at these, regardless of what kind of movement I'm looking at, I mean, we're looking to make the movements relevant. We're looking to get information from it. Most important information, at least what I'm looking for, is okay, symptomatic response. Okay, are they peripheralizing, centralizing, or is the pain increasing, decreasing, or are the quality of symptoms changing? That's the information I'm looking. Um, yeah, we're looking to see, just the general movement, things like that. But person's here because they're symptomatic, and for some reason, right, we need to know if there's any kind of pattern regarding movement. So, I mean, I usually tell the person, hey, you're gonna be doing, I'm gonna ask you to do certain movements. I'm gonna be asking you, if your symptoms are changing in any way while you do, asking you after. So, I just need you to be on board with that because I mean, asking them the entire time to the point where it may
True.
be a little bit annoying, but at least from my perspective, I really think it's necessary. Like I don't, it's not just, hey, do this once and then, oh, how was that? Oh, it was okay. I mean, that they answer my question, right? But compared to, okay, can you move can you reach your arm forward as high up as you can overhead? Okay. Um, did you have any pain when you did that? Yeah, it hurt like a 3. Okay. Did it hurt when you started? Did it hurt when it was in front of you? Did it hurt towards the end? Oh, actually, it really only hurt when my hand was in line with my shoulder, and then it didn't hurt at all at the end. Okay, different than if we had the opposite. Oh, it only hurt when I, really got to the the top of the movement there. Okay, what if I give you a little bit more pressure? Oh, it hurts even more. Cool, right? Different scenarios where if we're not looking for that kind of information within the exam, right? We're not going to be able to help the person as the best we can.
Now, when I just want to clarify, when we're talking about movement exam, do you
Yeah.
just mean like your basic range of motion testing and stuff like
Yeah,
that?
yeah.
Are you talking about a mechanical exam as well too, or is that
Yeah,
different for
I
you?
guess I'm going more. Well, yeah, I'm looking more towards. I guess I would. It's part of the mechanical exam. I'm not looking at the repeated movement parts yet. I'm looking at them performing
Yeah.
a movement a single time, and then the symptomatic response. So it would just
Oh,
be
sure,
right.
sure.
So it would just be what happened there, right? Increase,
Sure. So
decrease,
like I've
produce, right?
got it. Okay,
Compared
that makes more
yeah.
sense.
So it's if I were to write it on a sheet, it would be they did the movement once. Okay, what happened to the symptoms? Right, we don't have information on anything after yet because we can ask them if a single movement was provocative enough that they have worsening, maybe better symptoms after. But we're really if I were to write it on a sheet, it's just they did the movement once. Just want to know what happens when yeah.
Yeah, sure. I think that is a good clarification that we can make for people who
Yeah.
are listening too, because like I have a tendency, and definitely not a good tendency. I use a mechanical exam and a repeated motions exam
Hmm.
interchangeably, versus just going through their range of motion or the physical exam. That to me would be just getting their ranges and baselines down. Mark may use it a little bit differently just based off of his training with MDT, but that way everyone is kind of on the same page in regards to our definitions and terms. So the other thing that we haven't touched on yet is neurodynamics in joint moves during your
Yeah.
physical exam.
Yeah. So I guess we're getting into
How?
like um generally like I guess we agree that the stuff we've spoken about previously is really where we get good information, and then now you're touching on some maybe a little bit like fringe type things, but yeah, you get some good information from it. Maybe not the first thing you're going to looking at something.
Yeah, things are definite to me at this point. Things have definitely dwindled down in regards to their
Yeah.
impact or their potential validity. Um, but I think it's funny because these are things that are considered to be like really important. They're really stressed in school,
Oh yeah.
as well
It's like
as
look at the eval form pick, and it's like shoulder, and it's every single type of glide you could do, and it's like you can comment on the mobility in like so many different. Just like I mean, it's I can just from looking at the form, I can kind of guess in what period of time this was, but it's something that's still okay. I'll let you finish, as this is going to be a whole nother episode. So we'll speak about it generally.
um I think the other thing is for like neurodynamics in particular is um it's used in so many clusters for us, so that it seems to have a very high level of importance, especially for cervical radiculopathy. It's definitely part of the radicular cluster, and so that to me is like, sure, it's going to help us be able to diagnose it. But I think that there are plenty of other ways that we can still diagnose that condition, or be able to determine those symptom presentations. That for me, there's so many times where if you treat their issue and you don't actually get a decrease in their neural tension, you don't get a change in their neurodynamics, but their function's better, their pain is improved, their
Yeah,
symptoms have
yeah,
improved. So, like,
which I'll build
is
on
it
that
really
too.
that
It's
important?
like you're gonna get that should I put it? We kind of talked about this like we'll talk about some future touch on like hierarchy of like s- uh, objective response to movement. Yeah, like neurodynamic, it seems like any kind of movement you're going to, tension or decrease tension in the nerve some way. So you're getting some kind of input regardless of the. And sometimes you just have like a transient, non-specific response to neural tension with movement, and it's but it's not like you know, is it going to last? Is it by the patient? Is it really like important? Is it enough that it does it give us enough information if they do have a good decrease in quote unquote neural tension that it leads us to believe they're going to have a good prognosis. Similar to what you said, like if it doesn't change, is that important to us? If they subjectively reporting that their pain's better, right? Yeah, it's just not. Um, I mean, I definitely look at it, especially if someone has symptoms in like a peripheral nerve distribution, but you know, it's not. You know, if it if all their other symptoms go away and they still have a positive upper lower limb tension test, uh, I don't care too much about it. How about you? Do you find like
Yeah.
if they have a lingering quote unquote impairment when it comes to neural tension, or are you like, oh, we gotta address it, we gotta throw those tensors in there, gotta be cranking on it, all day, or
No, to
leaving it
me, it's
there?
like if it doesn't change, like if they're positive bilaterally and it doesn't reproduce symptoms, then maybe that's just how their body is.
Yeah,
So I don't put a whole lot of stock into it. I try to at least always capture that information at baseline. I do it less for sure for upper extremities. I just don't put nearly as much a stock into it compared to lower extremities. But when I do that, I want to make sure, is there a difference left versus right? Okay, that definitely puts a little bit more weight into it. And then the second one is, does it recreate their pain? And if it does, then I'll put I'll definitely put more stock into it then at that point. And so if we're able to make a change through like, so my go-to would be a repeated motions exam. So if I'm able to make a change in their neural tension through repeated motions, it already tells me what the problem is. And then it already told me how I can help to remedy that just through treating their spine. It isn't necessarily an issue with the peripheral nerve
yeah, you're
itself, you
treating it
know?
centrally, right? And you're getting the response. So do we have to go peripheral? Why
Yeah.
not? Yeah,
That's where it's like that information I think is like it's helpful, sure, but I think it can definitely be confusing for a lot of people if they don't keep things like more simple. Like because
yeah,
you just kind of get lost in the weeds with that kind of stuff.
yeah,
At least that's how I see it.
yeah. No, that's my experience as well. I had some more specific like classes on that kind of stuff, like coming out of school, and I kind of jumped on that train, but it just doesn't like it. Um, it just didn't seem like it was like a real viable. Like some people just have like that baseline tension, and it just wasn't related to their symptoms, and then you get like, but then you think it is, then you keep quote unquote treating it, and then it's just you get a variable response, and then just like all over the place. Compared to if you're just looking at like talked about this those basic important things, movement probably being the number one thing we're looking at, and then just the response to movement. I feel like you get a lot better idea of what's going, or at least what's how the patient's symptoms are behaving.
Yeah, I think like the main topics that we talked about previously in this episode will capture like 75 to even like 90% of
Yeah,
the things that you need.
for sure, for sure.
Like one of the things that I think is interesting is like if you're checking joint mobility, for example, if they're not moving well, like you can tell pretty quickly that the joint's not moving well
Yeah,
either.
yeah. I was
You
just gonna
know,
say that. Like, mean, I can think of the amount of people where it's like, usually like middle or older males where they have like go to do a post or inferior glide on their glider humor doesn't move, but then stand them or before you have done that, they're standing up and they have near full shoulder flexion. Like clearly their body's adapted and found the way to move, right? I don't know, um, so they can quote unquote do it. You can talk about quality and stuff, but um, are we really going to be able to measure an increase or improvement in that inferior glide? And furthermore, they have that full range of motion already. Like, do we need to address it? Is it an impairment? I think that's why it
Yeah, does it
falls.
matter?
Yeah, is it relevant? If that's why it falls low on our list of things.
Yeah, and to me, like there's certain joint mobility things that I think are maybe a little bit more important than others, especially for like daily function. And I'm sure that you'll probably notice like trends here for people where they're like, oh, they're going to be tighter in certain mobs compared to others, so there are certain ones where I'm just like, I really don't put as much weight into it. For example, like one that I can think of that I'm like, oh no, the end field matters to me
Yeah.
a lot is knee extension. Knee extension end feel is super super important. Same with flexion. If I'm hitting a hard end feel at either of those, I'm gonna be pretty concerned. If I hit if I don't get that springy end feel that I'm looking for flexion or for extension, like we're taught traditionally that knee extension is supposed to have a hard end feel, right? Because you're just running into your bone. There needs to be a spring to that. Like you need to be able to hyperextend. It needs to actually be able to bounce. So if I don't get that, if I don't get that, I'm concerned. So it not as in like it's a red flag, but it's just something that I need to address. So I think that's where.
Yeah, that scenario compared to where, someone's got it's a little bit stiff, but different.
Yeah, for sure, for sure. Like hip flexion, for example. Some people move up there no problem. Other people, they're stiffer, and then they're just like, yeah, I don't have anything. That's just how it is.
Yeah.
So that's why I personally just don't put as much weight into it, because I'll be able to assess it based on how they move and their quality. Like that's going to matter a lot more to them, as well as for me personally.
Sure.
But so I think that covers all the different aspects of of our objective exam. Is there anything else that you would really put in on there that you feel like we might have left out or anything like that?
Nah, nothing right now. I mean, there's certainly different situations. I'll look at different things, but I mean, like you said, I would even said 90% of the information you need is covered by the things we talked about today. I think that's a spot on number. You get so much out of, just to recap: range of motion, movement loss, MMT. Whether you're providing resistance through the range, whether you're doing it as a resisted isometric by their side or sitting, whether you're doing it, however you're testing their strength, right? That's going to give you more information. And then just the symptomatic response to movement, to resistance. It gives you so much information to work versus getting all lost with different kinds of joint mobility, degrees of joint mobility, tension tests, special tests for different joints. All this stuff can come into play, but I think if we're working, or at least working with the identifying impairments with the kind of standardized baseline things such as range of motion and strength testing, that gets you most of the way there.
I think it's so funny because that you say that, because special testing is such a big part of what is taught in PT schools, and we completely skipped over that because it's just not
on this
something
episode,
we typically do.
It wasn't even, not even on the list. We're just like,
yeah, because like if you do special tests, the thing that I don't really um appreciate about special tests is that they don't help you identify the deficit at all.
No, you just know that a test is positive or negative.
That's it.
Yeah,
But
like,
all the
what would I
other
do
stuff
with it?
tells you deficits, and that's what our job is to
Yeah.
identify and to treat the impairments, right? But these tests that they taught us were super, super valuable don't tell us anything valuable about our patients
Yeah.
for the most part.
Oh, yeah.
Sometimes they do, certain ones, but a large chunk of them I just don't see as much merit as we've been told to believe.
Exactly. I mean, we can use them as comparables and stuff, but I think there's better comparables. But like you said, it's just like, oh, when you point your thumb down and your shoulders like this and give resistance, it hurts. Okay. Well, thanks. Now I'm gonna check the box and
That's
in
been
Epic, and
done.
it's gonna turn red, positive, and I'm gonna move on with the rest of my day.
So yeah, I think the things that we spent a whole lot of time on today, just like Mark said, range of motion, manual muscle testing, and then deriving more information from those two aspects, like the movement quality and whatnot. But I think that covers like an overwhelming majority of what you need for like a lot of your patient population. Anything else you want to add, Mark?
Yeah, I think we covered most of it. I mean, I think in future episode we'll talk about more of those the value, even if it's small, like the kind of more fringe measurements we talked about, like neural tension testing, special tests, things like that. But I think the things we talked about today really cover most of what you're looking for, physical exam. All right. Well, thanks for listening, everyone. We hope you enjoyed this episode of the PT Good podcast. Remember to leave a like and subscribe on whichever platform that you're listening to us on, and we will see you on the next episode.
Missy, love you. Bye.